now I'm going to convince you why you should change your practice and give a Lipitor when somebody comes in with ACS. Any of you do that? Any of you do that? Two of you do that. Well, the argument for it is actually pretty straightforward. The reason I say it is pretty straightforward is because everybody who comes in and admitted to the hospital with an acute cardiac event is supposed to be discharged from the hospital on a statin, no matter what your cholesterol is. It's irrelevant. It's 130, whatever, it doesn't matter. You're supposed to go out on a statin because statins have been shown to decrease the rate of recurrences of cardiac events, and the number needed to treat for 5 years is something like 50. 50 people treated, one will get benefit if given for 5 years. Certainly not a slam dunk, great return on investment, but it's a lot better than, 200 people being treated who have not had an event and we're trying to prevent an event. So that everybody's kind of disagreeing. That's probably kind of a reasonable thing to do when you look at the math, the economics, et cetera. It is still relatively expensive. If 1 in 50 people get benefited for 5 years, so 50 people take that stuff at $1,000 a year if they're taking name brand stuff, that's $50,000 times 5 years, $250,000 to prevent one coronary event. And that doesn't mean that's a death necessarily. So the fact of the matter is that there is, people will say, okay, I'll spend $250,000 to prevent one of those. And the reason that people recommend statin, or people are recommending statins, or at least some are, is that they do a lot of stuff that other than lipids. They basically, if you look in the chapter there, the theory here is that they are known to decrease platelet adhesion, they're known to decrease thrombosis, they are known to increase endothelial function. That's like the endothelium has a job. This endothelial function, they decrease inflammation, and they increase plaque stability. All of them, those things, unrelated to decreasing your cholesterol and LDH and all that other stuff. And one of the things that's kind of been shown is that in the setting of persistent elevation of inflammation in your body, as reflected by like CRP measurements, those people who have persistent elevations of CRP in the setting of an acute ACS tend to have more cardiac deaths and reinfarctions, nasty things, than those who don't. And it has also been shown that there's a relationship. It hasn't been proven by any randomized controlled trials, but there is a relationship between statins given to people who have elevations of their CRPs and better outcomes. And so the idea here is that the anti-inflammatory effect may be what is the operant issue here in this subset, because in some patients who have no elevations in their CRP in the setting of an acute coronary event, there doesn't seem to be any advantage. So the idea is trying to tease out, well, what subset will get benefit and what subset won't get benefit. It appears to be relatively irrelevant if the American Heart Association and the American College of Cardiology say all of these patients should be sent out on statins. They also say that you should measure people's cholesterol fasting cholesterol within 24 hours of arrival at the hospital in these admitted cases, which is kind of like, well, I guess it's good to know what it is, but if it doesn't matter what it is, you're going to get it anyway. It's kind of like, well, okay, now I know what it was, but we're going to treat it anyway, independent of what it was. It's kind of like being a scientist of sorts, but this is not necessarily related to the level of cholesterol, the reason that you're taking this stuff, because it appears that all of these other things basically are operating in terms of helping out the situation here. So the first two citations, there's no abstracts from them. This chapter was written by Jim Ducharme from Canada, and I kind of put my 2 cents in towards the end of the chapter as well. So Jim put in a couple of citations where there are no abstracts, but he kind of gave you the bottom line on those papers. So the first citation there, where there's no abstract, suggests that there's increased survival in those on statins with the CRP level elevations given within 1 week of treatment. So a lot of the papers are 1 week, 48 hours, 24 hours. There are certainly no papers that say let's look at statins given in the emergency department. That's clear. There's none of those. And so everything we're talking about is an extrapolation, which ultimately comes down to, well, if you're going to give them anyway, and there may be some theoretical benefit to giving it sooner rather than later, and I'll show you the papers that talk about 24 hours and 48 hours. If that's the case, then why not give them in the ER? And the other argument for that is this one that's the second paper that's not got any abstract. He says statins given at the time of a PCI, which is basically often done in the United States, as soon as you come into the hospital, in association with statins given to patients getting PCI, there was a 26% of the patients had an increase in 6-month survival. So again, no causality, a relationship, maybe, kind of thing, an association, yes. So that basically suggests that PCI, statins, maybe some benefit. And so there's going to be a lot of where there's smoke, maybe there's fire kind of thing that says, well, why not do this kind of thing? And then there's this idea of, and particularly in the older patients who were discharged after an ACS, they forgot to give them their statins, or they forgot, you know, they didn't kind of realize it was a good thing to do. And so that there's a suggestion that if you start them in the emergency department as part of the order set, that they will get continued and it won't be forgotten kind of thing to do that. That's kind of probably the weakest argument that you can make, but it's an argument because we've done that kind of thing in other situations, and particularly when you're talking about steroids in asthma. You know, the idea that people would be given steroids in the emergency department and then discharged on steroids so that the family doctor doesn't forget, you know, maybe you should have this person on inhaled steroids because they should have been on them before they even came to the emergency department, kind of thing, because that's considered to be now the fundamental treatment of asthma is these inhaled steroids kind of thing. And it just flipped 180 degrees. It used to be adrenergic. Well, you're flunking those. Okay, let's add some of the steroids. Then it went, you know, the other way around, and now it's steroids, and if that's not doing it, then supplement with adrenergics. That basically is something that would be intellectually driven in the emergency department by us discharging people on inhaled steroids, which in the distant past, that would be never, ever considered to be done you'd have to call up the doctor and say, okay, if I do this kind of thing. So that's changed, and this is kind of the same theory here. So clearly there are no studies. Somebody needed to do a study on statins in the emergency department. I mean, that's what we need to do. Abstract number 1 is from the University of Michigan. This is an interesting study. They had 1,600 statin-naive patients with unstable angina or AMIs. One of the things that you ought to look at in these papers, particularly the ones that don't show really any benefit to statins, is to see what are they treating. You know, some of these registries that talk about people are admitted to the hospital, just include every soul has got some kind of ACS, whether it be STEMI, non-STEMI, or new onset angina, but no leak of troponin, et cetera, in a normal EKG, but it turns out to be cardiac chest pain. And when you do that, you really potentially dilute the effect of statins in the setting of STEMIs, then maybe less so non-STEMIs. And the question is, does it work? Does it do anything in unstable angina? Well, if you're going to rank those three disorders in terms of the risks and potential benefits of the therapy, as I mentioned yesterday, you would always take the sickest patients to show that your marginal therapy is going to make a difference. And in this case, the sickest patients are those who get STEMIs. I think most people would agree that if you were going to pick out of those three, you would choose not to have the STEMI version of those threes. So these 1,600 statin-naive patients, meaning they came in, they were not on statins when they arrived at the hospital, who had unstable angina or MIs. They got statins within 24 hours, at least 3/4 of them, almost 80% got statins within 24 hours. And the other quarter got statins longer than 24 hours after their arrival. Early statin patients had increased cardiovascular risk and comorbidities, because we're not talking here about a randomized double-blind trial where you would try to adjust for, you know, morbidity and cardiovascular risk, et cetera. So in this study, just by chance alone, these patients who got statins were sicker patients, which is kind of biases the favor of this study into not making statins work. But in any case, early statin patients had increased risk and comorbidity issues kind of thing. There was no significant difference regarding inpatient mortality. The inpatient mortality in the study was extraordinarily low, 1.64% on statins, 1.64% on statins. But remember, they're not STEMIs. Some of them are unstable angina, so you're going to get some low numbers. And those who are not on statins, 2.26. So it's a 1% absolute difference in this all-comers. But if you look at the abstract, it talks about those patients who had complications while in the hospital. Like there was a decrease in pulmonary edema in these patients. 6.9% had pulmonary edema with early statins, 15.8% without statins. And cardiogenic shock, 2.2% versus 7.3%, a threefold difference. And atrial flutter and atrial fibrillation, decreased rate of that, 5% versus 9%. Major bleeding, I have no idea why major bleeding was less. Maybe they were just kind of, again, an association. 4.9% versus 10%, so it was twice as high. And the composite endpoint, here you go, composite endpoint of death, reinfarction, or stroke, 7% versus 10.4%. There was no difference at 6 months regarding these individual variables. So basically they said that in a large group of patients who had unstable angina and STEMIs kind of thing, so this kind of a hodgepodge, the subset of complications was much less in those patients who were on statins in this non-randomized trial. So, okay, fine. I mean, I'd like to have less cardiogenic shock, less arrhythmias and those kinds of things. And 2 is a kind of similar paper. It's 2,200 patients. These are large studies. 2,200 patients admitted to 369 French emergency, French ICUs. This study was done in 2000. Now look at this, half the patients got no statins before or within 48 hours. So they didn't come in on them and they didn't get them early. 1 out of 6 got statins before. 1 out of 6 were on statins when they came in. Their doctor had prescribed them for them, and they also got them within 48 hours. And a third of the patients were newly put on statins. They had not been on them before. As soon as they came in within 48 hours, they got statins. The composite of cardiovascular death and recurrent MIs at 1 year was about 40% lower in the patients who were started on statins when they came into the hospital, started on statins. What this study didn't find, however, is that people who were already on statins had any benefit. Those people who were already on statins and continued on statins in the hospital didn't seem to get any benefit, which is kind of like, how do you kind of figure that out when in fact the benefit of early statins within 48 hours on patients who were just started on for the first time while they were having it was, well, maybe there's some explanation. I just don't know what it is. It doesn't exactly pass the sniff test, but here's just a little bit more evidence that suggests this may be a reasonable thing to do. The next paper there, number 3, says this is one of the reasons you start them in the ER is because maybe people will continue them throughout the hospital course and discharge them on them, which everybody agrees is a reasonable thing to do. That's kind of probably the weakest reason to do this. They talk about registry data. There's 4 registry data papers in here, 2 of them with abstracts and 2 of them without. And these are large papers, 4 and 5, and then there's 2 other citations that Jim put in here that don't have abstracts, but in which he summarized the key points. All of them suggest the benefits of early statins. Every one of them does. They said, and as a caution, they said, you know, registry data is voluntarily submitted, so you're not sure that it's all been submitted kind of thing. And you don't necessarily know why people were or were not given treatment in the registry. There might have been good reasons that they got or did not get treatment, but nobody knows that because the registry data is just data, yes, no kind of thing. And cases with poor outcomes, they say, are often excluded in registry data. I'm not quite sure why that would be. And the data is not routinely verified. It's just kind of like, well, give us what your results were, but we're not going to check on it or not. And I think all of those are kind of, yeah, that may be true, but they're not like particularly compelling reasons to discard registry data. The first paper there, 7,700 patients. Now these are STEMI patients, so we would be more interested in this study, STEMI patients getting statins within 24 hours. 7-day all-cause mortality, 7-day all-cause mortality, 0.3% versus 3.4%. Last I heard, that's a tenfold difference in mortality. Now, this is registry, not randomized double-blind, and the numbers are almost hard to believe. The numbers are hard to believe. 0.3% mortality in STEMI on patients started on statins within 24 hours versus 3.4% not. 3.4% is a great mortality rate for you to have for your heart attacks. I mean, that's kind of, that's very good. So that number is fine. The 0.3% number is the number that's kind of hard to believe kind of thing. There was no benefit in non-STEMI patients, which kind of makes the point. STEMIs are bad, non-STEMIs are less bad, and unstable angina is less bad than that. And so this paper differentiated and said STEMIs got the benefit here. Now, again, registry data. Number 5 is this Genentech Near-Me registry that some of your hospitals probably even participate in. This is 174,000 heart attacks. Of that 174,000 MIs, 22% got statins within 24 hours. And half of those patients were on them prior to arrival. You know, their doctor had prescribed them. So this does make this same kind of thing as before. Newly onset statins versus people who are already on statins. Newly started patients on statins, the inpatient mortality was 4%. That's pretty good. If you were continued on statins, because your doctor had prescribed me, continued in the hospital, your mortality is 5.3%. So it's a 1.3% absolute difference. Another way to say that is like a 25% improvement in mortality. 5 versus 4, 20% absolute mortality difference. So that's pretty good. What happens to the patients who were not on statins and were not put on statins? Their mortality was 15.4%. We're talking about 4% versus 15%. Now, 15% mortality is really, really high. How can you explain it? Well, this registry had 174,000 patients. I'm not exactly quite sure how you explain it. Lucy, you got some explaining to do. But the fact is, it was really high. And if you discontinued statins, mortality was 16.4%. That's clear. Don't do that. Do not stop them. You know, and it would be potentially an easy thing to do. You know, in the heat of battle kind of thing, where everything's going on, you forgot to write down their Lipitor. They came in on it. You forgot to put them on it because you're too concerned about 2Bs and 3As and this and that kind of thing. And this suggests that withdrawing patients is not a good thing to do in the setting of an acute MI. So those numbers kind of are a little hard to kind of jive. You're not supposed to have a 15% mortality, no matter what the heck you do in the emergency department, in the hospital. But they did. 174,000 patients, hard to deny that. And, you know, mortality is pretty black and white kind of thing, you know. Very good question.
Could it be that the ones that didn't get the statins or discontinued the statins were so sick that they were intubated, they weren't being fed, they didn't get anything down the NG tubes?
Well, that's really cool, because if you read the chapter, the doctor who wrote this chapter says, were statins given to the least ill patients, and were the sickest patients not given statins? So you can't correct for that because this wasn't a randomized trial. So your theory there is also brought up by the doctor who wrote the chapter to suggest maybe that explains this difference. Maybe that it is. Although it is hard personally for me to accept the fact that systematically the sickest patients didn't get statins.
Well, they may be intubated, they may not be fed, et cetera. They may be hypotensive.
Yes, but we're talking about a mortality rate of 15% in a subset of patients in a registry of 174,000 cases. That would be a lot of patients who were basically moribund with their MI. So I kind of don't think that probably is true, although you would have to think about that as one of the explanations for these apparent discrepancies here. Japanese, go ahead.
Yeah, you know, just the subgroups within the STEMI category. I mean, there are very extremely sick, you know, going to die patients with PMIs, and then there are patients with inferior MIs that are not going to die. And so unless they really randomize this and find the subgroups and equalize it, then I just don't see the status very neat.
Well, in all comers, your mortality from a heart attack, independent of where it is or what it is kind of thing, is probably 6% or 5%. So that suggests that the vast majority of people who have heart attacks with current therapy aren't going to die. So yeah, there are going to be some sick patients in there, but the vast majority of them, 94% or 95%, are going to walk out of the building. So I think that you both have reasonable points, and this is more part of this where there's smoke, there may be some benefit in these cases. Then there's these two other papers that are cited there where the abstracts aren't there. This Japanese registry, 4,000 folks, compared statins before discharge and not. Well, the statins before discharge is, come on, give me a break. I mean, you might be giving them 5, 6, 7 days into an admission or something like that. The hazard risk for death and reinfarction in that study was 0.6, so it's about 40% less if they were discharged on them versus not. This is kind of making the case why they ought to get them sometime in their hospitalization and continue on them. And then there's this last Swedish registry. This is old data, it's 10-year-old data. They compared statins before discharge versus no statins. It's kind of the same as the paper before. 1-year mortality decreased early statins. The relative risk there of mortality was decreased by about a quarter. So one paper says 40%, the other paper says a quarter. Clearly making the case that statins should be given some time during their hospitalization and continued thereafter. And now the next question is, what do the randomized controlled trials show? Well, there aren't any of certainly statins in the ER setting. There was a randomized controlled study that looked at 2B3As, and as part of that study, they also looked at whether they were on statins or not. That's paper number 6. So this is about 4,000 people who got early statins, which they said that were statins within 7 days, versus 8,400 people who didn't get statins within 7 days. Now, this is another paper where you have to be careful. These are ACS patients, not heart attack, not myocardial infarction patients, limited to ST elevations, et cetera. This is like everybody who came in with something wrong with their coronary artery disease. And in this study, it was randomized for 2B3As. And then they said, well, let's kind of also look at whether there were some issues regarding statins or not statins. But that wasn't the primary purpose of the Symphony study. There was no significant decrease in 90-day outcomes regarding death, MI, recurrent ischemia, or rehospitalizations. There was a decrease in strokes. So maybe say, okay, fine, this paper, no cardiac benefit, but decreased stroke by about half. And then there was this other study, this meta-analysis of trials, number 7, 12-trial meta-analysis involving more than 13,000 patients, statins within 14 days. There was no difference in 1 or 4 month benefits regarding MIs or death or stroke. In this paper, stroke didn't tease out. But again, patients were ACS patients, not STEMI patients. It was interesting, too, that they said, well, what was the risk of myopathy? So is there any harm to giving a statin? Well, maybe. What myopathy? Okay, how many? 1 in 1,000 patients got myopathy. The controls? Well, let's make the denominator the same. 10 out of 10,000 patients given statins developed myopathy. 10 out of 10,000. Controls? 6 out of 10,000. So because there's this case now to make statins over the counter and not require a prescription. Put them in the water kind of thing. Whether that's a good idea, probably a really bad idea. And what about rhabdomyolysis? Kind of, the ultimate version of myopathy. With statins, 0.05%, which is 1 in 2,000 people taking them would potentially get rhabdomyolysis in this. So that's kind of looking at, well, what's the downside of giving this stuff in terms of... the conclusion is there's no compelling data that says you should do this when they come in the emergency department. And I think that that's true. But I think there's no compelling data not to do it. And it's always one of these things about harm versus potential good. We're here talking about potential good. I think there's enough papers that suggest there's some potential good here, particularly in the sickest of the subset with the STEMIs. And that being the case, you'd have to say, well, what is the downside? Is the downside I'm going to harm you? The downside is every soul who comes in who has an ACS is supposed to go out on it, and the literature reasonably supports that. Okay, so that being the case, the question is just when? And if you take if there is a benefit, would it be the sooner the better? Well, it sounds logical. Maybe that's not true, but I don't think there's any reason not to. It kind of goes like the argument about giving acyclovir to people who have Bell's palsy. Is that a good idea with the theory? Well, some of these cases are really not idiopathic. They're actually caused by some kind of, what is that virus? Herpes virus kind of thing, and because there's some kind of maybe evidence of stuff in some of the nerve fibers that there's some evidence of a virus there, but you can't really prove it definitively. And in those studies, the position, my position was, well, why not? I mean, Bell's palsy is a nasty thing to have, and it always doesn't go away. Sometimes it goes away, but sometimes it doesn't. Ask Ralph Nader, he still has a residual of his Bell's palsy. So the fact is that the theory was, well, it may help. It's ultimately been proven that that doesn't work. That is proven, that acyclovir. But in the meantime, we didn't really know the answer for sure. So the kind of thing was, well, are you going to give it or not? And the answer is, I'm going to give it because they're just expensive M&Ms. They're not going to hurt you to take acyclovir. It's not. And if you can afford $100 for it at the time, when it was, a trade name product, would I pay $100? What if I had Bell's palsy? You better believe I would. So the question there was risk benefit. Now, some people are really rigid about this and say, unless there's proven benefit. But one of the problems is it may take a long time to prove benefit. And in the meantime, all of these patients got no benefit because you're being, a hard ass about this and saying, well, there's no definite proof. No harm. And in these cases, you're going to be required to have these patients leave on statins. That's not negotiable kind of thing. So that being the case, the question is, why not start them in the ER? Anybody have a point of view on this?
My question is, where does this extrapolate to taking the non-ACS, never had a chest pain, I've got some hypertension, I'm 56 years old, and my doctor has me on a statin. And I look these people up and their cholesterols are 160, 170, and their doctors have on statin because the internists have been totally convinced that this thing prevents myocardial infarction, 25% less MIs, and even on the Jarvis commercial, they have just a real quick one-liner in certain patients with certain conditions, meaning you've had a heart attack before, but they're pushing it to the internist. I don't have a patient who comes through the door over the age of 25 that's not on a statin.
Well, that's on the bonus section, because I wrote the bonus section, which is a little bit more generic because a lot of you are on statins kind of thing. And it gets into this issue about thresholds for ordering statins and potential benefit. So some of that I included in the papers when we talked about the Cholesterol Newsweek kind of trial. But a more fundamental issue is who ought to be screened. And in the United States, basically, they want everybody screened and everybody who has high cholesterol treated. And in New Zealand, they say, no, don't screen everybody. Just screen people who are at higher risk, family history, hypertension, whatever, diabetes, that kind of thing. But don't certainly screen the whole population. And you look at some of the numbers in the bonus section there about when we're talking about populations of 300 million people kind of thing, there's got some serious numbers come into play here. So the U.S. standard would result in twice as many people getting screened for cholesterol as the New Zealand standard. When they compared the New Zealand standard and the U.S. standard, twice as many people would get cholesterol treatment in the U.S. In terms of the prevention of heart attacks, no difference. They basically are more selective. Outcomes are the same. They treated the high-yield cases. We treated the high-yield and the low-yield cases together. And as you might expect, there's essentially no incremental benefit by treating more patients who have lower risk. And I think that one of my favorite analyses is that there's a thing in there from the University of British Columbia. You go on their website and they basically have analyzed all of this stuff. And I distilled that in your chapter there on the next to last page about the return on investment here in terms of whether you're using a generic statin versus a trade name statin. And the numbers, the sheer numbers are extraordinary. The New Zealand people say the number needed to treat for 5 years to prevent one coronary event. Using the US guidelines would be about 200 people. Using the New Zealand guidelines would be about 100 people would be on statins in these using these two standards. One of the other things is that we have to be careful about extrapolating. Women, again, turn out to be, if you look at the analysis by the Department of Pharmacy, University of British Columbia, the benefit for statins in women are much less than they are in males. No decrease in coronary events in females per the University of British Columbia analysis. So that's another issue, and it kind of goes along with the idea that women don't seem to get much benefit from the use of aspirin to prevent coronary diseases, coronary issues at all. And the last thing is, and that's in there as well, is this business about all-cause mortality. Yeah, if you take statins, you'll decrease the number of some heart attacks that people will have, the yield being pretty low, costing about $1 million a heart attack if you treat 200 people for 5 years. 200 people treated for 1 year with a Lipitor, brand name is $200,000 times 5 years. It's $1 million to prevent one of those events, $1 million to prevent one of those events. So yeah, you may decrease mortality a little bit, but all-cause mortality is not decreased. All-cause mortality is not decreased, and that's reflected in that chapter by suggesting that maybe statins increase your risk of death by for some other reason. Maybe there's a little bit more cancer and a little bit more this and a little bit more that, because they can see no difference in all-cause mortality. Yes, it drops cardiovascular mortality a tad. So that would suggest that when you look at a population, we haven't made it clear that we're certainly not getting our bang for our buck in terms of everybody spending this. And in the Jarvik commercial, there's a picture of him rowing in a boat. That's not Jarvik rowing in the boat. That was a body double. It was kind of like an implied, look at the vitality of Dr. Jarvik kind of thing here. So they had to get somebody else to row the boat, for crying out loud. Dr. Jarvik wouldn't row the boat. All right, let's stop here.